Hello and welcome to our summer webinar policy series. I am Ebony Gabriel, a member of the Graduate Student Committee. I serve as the Applied Work and Policy Officer. And today we will be talking about the war on racial equity. This will be Battle 1. And we will be discussing researching abortion, examples and strategies for informing policy. I would like to introduce you to our speakers. We have Dr. Sara McClelland, who is an associate professor of psychology and women's and gender studies at the University of Michigan. Her research focuses on feminist research methods that highlight how people develop and maintain a sense of deservingness and how intimate lives are impacted by the discriminatory public policies. This has included studying the role of racism and attitudes towards abortion, the effects of absentee only until marriage sex education on young adults, and gaps in clinical care for women diagnosed with cancer. More details about her research and publications can be found at progresslab.info. She will be speaking on how the overturning of Roe versus Wade is intersected with race and gender, specifically the associations, stereotypes about women of color that affect how abortion is imagined and policed. Our second speaker is Sara K. Redd. Dr. Sara K. Redd. She's an Atlanta-based interdisciplinary scholar advocate studying sexual and reproductive health, policy, and equity. Trained in health policy, health services, research, and social science, Sara explores structural determinants of access to and use of comprehensive sexual and reproductive health care, and she downstreams health outcomes in the United States. She employs a socio-ecological framework and reproductive justice lens to her work, paying particular attention and devotion to sexual reproductive health, equity, and the experiences of those living in the US. She also works closely with local and national reproductive health rights and justice organizations to support and facilitate community-led and community-driven sexual reproductive health research. She is an assistant professor in the Department of Behavioral, Social, and Health Education Sciences and the director of the research translation with the Center for Reproductive Health Research in the Southeast, which is at the Rollins School of Public Health at Emory University. In addition, she is thrilled to serve on the board of directors for the Atlanta Birth Center, Atlanta's only freestanding nationally accredited birth center. She will be speaking about how these policies have affected state-level access and about the health well-being of pregnant folks. Both Sara M. and Sara R. can speak to how their research is used in policymaking as well. So now I will hand it off to our speakers.
So Sara, you're gonna take it first?
Sure. I think that makes sense. All right, let me get my screen sharing going. All right. Hi, everyone. Thank you so much. Thank you, Ebony, for having me here. You got a double dose of Sara today. So I hope everyone's excited about that for your Monday. So my name is Sara Redd, and I, as Ebony mentioned, I have an incredibly long title. I'm assistant professor of behavioral, social, and health education sciences at the Rollins School of Public Health at Emory University. So today I'm going to be I'm going to be giving kind of a little bit of history at first over kind of like the basis of Roe v. Wade and the Dobbs decision to just kind of give us a little bit of kind of a foundation setting for this topic today. But then I'm also going to be talking about how these policies have affected state level access for individuals in the US, and also how these policies have affected kind of health and well-being of pregnant people and their families in the United States. So just quickly, here's a photo of my face and of my face on the screen. You know, and I'm actually realizing I don't know that I really need to do a bio since Ebony did such a great job of introducing me, but I will just say that, yes, I identify as a health services researcher who is interested in structural determinants of access to and use of sexual and reproductive health services in the United States. And I'm also going to give a quick shout out to my research home, which is the RISE Center, the Center for Reproductive Health Research in the Southeast. I am privileged to be one of the administrators of our RISE Center. And we are a collaborative research center that is comprised of a network of stakeholders that are accountable to reproductive health, rights, and justice in the US Southeast. And so RISE is based at Emory, at the School of Public Health at Emory. And our mission is really to improve the reproductive health and equity of people in the US Southeast through transdisciplinary research that informs social systems and policy change. So we're really interested in doing research that is kind of looking at kind of the higher levels of the socio-ecological model, that's really interested in kind of what we're talking about today. How can research actually make a difference in terms of our systems and in terms of policy making? We include a wide variety of stakeholders, including community-based organizations. We have people at universities who are really accountable to reproductive health, rights, and justice in the US Southeast. And another large component of our work is training future professionals at all education levels to go into reproductive health, rights, and justice with a knowledge of research and how it can be useful to people for their work. That's a little bit about RISE. Now we're really going to focus on kind of the meat of the presentation today. So this graph depicts the number of clinician-provided abortions in the United States from the original Roe v. Wade decision in 1973 to 2023. And I want to point out two things about this graph. First, the naming of clinician-provided abortions in the United States. This is really the understanding that we don't have good measures of abortions that are occurring outside of the formal healthcare system, including like self-managed abortion. The other point to make is this discussion of Roe v. Wade and what was Roe v. Wade. So Roe v. Wade was a landmark Supreme Court case in 1973 that established through the 14th Amendment a constitutional right to abortion in the United States. And this was the kind of main crux of what was overturned in the Dobbs versus Jackson Women's Health Organization decision in 2022. There is another court case that is relevant to this and kind of gets to the point about Dobbs called Planned Parenthood versus Casey, which occurred in 1992. And the idea behind behind Planned Parenthood versus Casey, so Roe established a constitutional right to abortion, and they essentially said states cannot restrict a person's access to abortion just to restrict it. In Planned Parenthood versus Casey in 1992, they said, okay, well, states can do some kind of litigation around abortion, but not so far that it constitutes an undue burden on someone accessing abortion care in the US. So those were the two really foundational court cases that cemented access to abortion care in the US, which the Dobbs versus Jackson Women's Health Organization case overturned in 2022. So apologies, that was a little bit of a detour from this particular slide. But what I want to highlight on this slide is, as you can see, the number of abortions in the US has steadily declined from the 1980s until about 2017, where it reached a historic low. However, what we have seen since 2017 is that that long-term decline has actually reversed. And so from 2017 to 2023, we have actually seen a marked increase in the number of abortions in the United States. Since 2010, over 700 different abortion restrictions have been enacted in states around the country. This graph shows the number of state restrictions that were enacted per year since 2010 up until 2022, again, when the Dobbs versus Jackson decision occurred. I like this graph because it shows that there are sometimes and in some dialogue that I have with folks, there seems to be a sort of myth that abortion started being restricted with the Dobbs versus Jackson women's health case. And I like this graph because it shows that that is clearly not true. The states have been enacting restrictions on abortion for decades, since the Roe v. Wade decision in 1973. And I like this graph because it really shows how much variation there was in state policymaking, even just in the last 15 years or so. So this is the most up-to-date map detailing the current status of abortion bans around the country. And so as of August 1st, 22 states ban abortion or restrict it earlier in pregnancy than was the standard under Roe v. Wade. And this actually only became 22 just a week ago when Iowa allowed their 6-week abortion ban to go into effect. An important trend that I want to highlight here is how, as you can see in this graph, these restrictions are really geographically concentrated in the southern region of the country and in the Midwestern region of the country. And in the South, abortion is completely banned from Texas all the way over to Alabama, all the way up to West Virginia and Indiana. So that's a little bit of kind of the stage behind these policies. Now we want to get into more about the implications of restrictive environments. So the main takeaway that I want to highlight is a conceptual model that I have put together, which really outlines the 3 main implications from abortion restrictions. And what we know from both people's lived experiences and also from the scientific evidence base is that abortion restrictions do 3 main things. First, they severely reduce access to abortion care. Second, they directly and indirectly increase the risk for adverse outcomes, including things like preterm birth and low birth weight, infant and maternal mortality, and economic hardship. And third, these policies disproportionately affect and devalue the health of those who are already experiencing and navigating structural oppression. So I'm going to go through each of those kind of one by one. And so getting a little bit deeper into that first implication about reduced access, abortion restrictions severely reduce access to abortion care. And they can do so via a number of different ways. Through decreasing provider availability, one thing that we've seen is that a lot of clinics have closed in the kind of aftermath of the Dobbs decision. They can also just make it more difficult for patients to get an appointment, longer wait times, and actually increases in travel time, distance, or costs of getting care. And that can include both, I need to figure out a way to get, if I am having to cross state lines to get care, that can be trying to figure out how am I actually going to do that. But it also includes things like lost wages, because you have to take time off work, securing childcare, possibly having to stay overnight, all of these different kind of structural elements. And again, so this graphic is from the Society of Family Planning and their We Count effort, which is just an effort to try to assess how abortion access has changed in the wake of Dobbs. And what you can see in this graph is that the kind of dark gray blue colors indicate decreases or reductions in abortions by state, where the orange color represents increases in abortions by state. And so this is actually an interactive graph online, so highly recommend going to check it out if there are any other data dorks in the audience like me. But you can really see, again, as we saw in the New York Times graph around kind of where the bans are really concentrated, you can see that if we overlaid that map with this map, they would look extremely similar. So we're seeing that the states in the South have really experienced the largest declines in abortion access, where and that really spreads into the Midwest as well. So in terms of increased risk of adverse outcomes, we have seen that abortion restrictions influence health via numerous pathways. First, we know that pregnancy and childbirth are inherently more dangerous than abortion. Thus, there's an increased risk of morbidity and mortality simply because you're staying pregnant. Second, people who are living in states with more restrictive policies also experience other structural barriers to healthcare, including the states that often have most restrictive policies also have the fewest supportive state policies, things like family leave, Medicaid expansion. Some of these other kind of like key policy, supportive policies are not present in states with these bans. Can also experience lack of health insurance, that Medicaid expansion piece, and I'm also coming from Georgia. That's a big, that's a big, flag. So this is something I'm intimately familiar with. And also lack of access to high quality and culturally respectful care. Additionally, provider shortages. So there are a number of different kind of state level structural barriers to care that really grow in importance when you're looking at this kind of a health issue. And then third, being denied wanted health services and also then having to navigate structural barriers and perhaps increased actually structural barriers to care all increase the psychosocial stress that someone might experience, which increases the risk for poor health outcomes. And while this figure is really kind of focused on the health outcomes piece, I do also want to point out that there are other clear socioeconomic implications of restricted abortion access as well, including interrupted educational trajectories, increased risk of unemployment, and increased risk of living in poverty and experiencing other forms of economic distress. And third, again, what we have seen through lived experiences and through the literature is that while these bans harm everyone, we've consistently seen that these policies disproportionately affect those who are already navigating structural oppression and structural barriers to health, wellness, thriving, and surviving, not surviving, thriving, including Black people, Indigenous people, and other people of color, young people, people who are living, or people with fewer years of formal education, people living in rural areas, queer people. There are so many individuals for whom these restrictions disproportionately harm. And really, in effect, these policies are real-time structural examples of white supremacy, of racism, classism, ableism, and other forms of systematic oppression in action. So I'm going to wrap up my portion of the talk by just giving a little bit of a preview of some of the ways that I really lead our work at RISE and in my own work to translate this research and actually try to get it really trying to get our research kind of into that policymaking sphere and trying to really connect that research to policy pipeline a bit. I'm actually going to skip over. Well, this is one piece that I will highlight, and this is particular both to RISE and also to my own work. But these are kind of some of the priorities and values that I really put in and infuse into my research translation in order to try to actually make it relevant for folks. So one, making our research more accessible. I'm sure it is no surprise to anyone who is on this call that research can often be incredibly siloed. It can be incredibly inaccessible to folks who are outside of the academy. And that's, something that we're just trying to change through really prioritizing digestibility of our dissemination products. It's not easy to just, well, first of all, there are paywalls to most articles, but it's also not exactly a priority or necessarily the most accessible thing to take like a huge research paper and just try to digest it all, particularly for folks who may be working in community spaces or are advocates. So we really try to produce products. We'll take papers and turn them into one-pagers or infographics or social media content, and really prioritizing making the information digestible. We focus on honing our messages to make our research relevant to whatever audience we're trying to speak with. And so policymakers are a huge audience for us, and also uplifting the work of our community partner organizations. I am going to quickly move through this just for time's sake, but I did want to give one example of this type of work that on both my and my colleague, Dr. Whitney Rice, who is the director of RISE. So Dr. Rice and I have actually had the opportunity to, within Georgia, participate in both legislative advocacy. So I've had the opportunity to present in front of the Georgia State Legislature numerous times. And actually, Dr. Rice was an expert witness in the a case called Sister Song versus the State of Georgia, which was challenging Georgia's 6-week abortion ban. And so it was a master class in patience and grace, watching her be kind of on the stand and get grilled by the defendant, the state of Georgia attorneys. It was really an incredible thing to witness. But I also, every year, usually 2 times during the legislative session here in Georgia, I have the opportunity to address the state legislature. So actually getting to provide some expert testimony, usually it's like a 2-3 minute speech or kind of just summary of the evidence base and kind of around a particular research topic. And that has been an incredible privilege. Lastly, and I'm actually just, okay, will be my last example, but we actually had, and I had a paper that came out through JAMA's open access journal last year, that was really trying to estimate the effects of Georgia's 6-week ban on abortion access. We had the journal article published. The next day after it was published, I actually was scheduled and I was speaking to the Georgia State Legislature. So this is a photo of me speaking to them actually the next day. And this little graphic in the side is an example of one of our 1-page documents that we took the big paper, translated it into just like a 1-page, what is it that you absolutely have to know about this? And I was actually able to hand out that handout to all the legislators that you see through this picture. And so it was kind of a real-time example of being able to interact with policymakers and kind of do some of that research translation in action. So I have spoken enough. I am ready to pass it over to Dr. McClelland.
Hi, everybody. I'm going to put my slides on the screen. It's really lovely to be here. And I think Sara and I, the 2 Saras today, offer a really lovely kind of combined sandwich of different ways that we can think about the role of psychological research, the role of policymaking, and how the two might interact. So when we think of a pregnant person, exactly as we just heard in Sara's really lovely presentation, there's all these barriers that are incredibly important to be thinking about. And we just saw a couple of examples in Sara's presentation, including state bans, including those who both receive care as well as those who assist in getting other people to care. things like 24 to 72-hour mandatory delays in getting abortion care, parental consent laws that regard minors. So these are incredibly important barriers that are incredibly restricting the kind of care that pregnant people can get. But let me also say that is different than what I am going to be talking about today. So I think really differently about how we should be addressing these issues around abortion care. And that has to do with how the US population thinks about pregnant people and the ways that that kind of imagery both infuses how people are imagining pregnancy in general, abortion care, voting, public opinion polling, and all sorts of ways that the kinds of thoughts and images and stereotypes around abortion circulate at the US population level. So a really different angle on the same story, which I think is a great way of thinking about this. So if we take this idea of what does it mean to be thinking about the pregnant person, I'm going to just do the tiniest gloss on the talk that I gave actually at the SPSSI conference in June. For those of you who want to see the much longer version, I think it's up on the SPSSI YouTube channel. But I'm going to just give 2 slides on the larger set of research that I presented last month. And really what I'm interested in thinking about is this imagined abortion seeker. And through a variety of studies with a variety of samples, different political ideologies, different ideologies around abortion. And let me also really state clearly across both pro-life and pro-choice samples, there is a consistent set of images that appear and reappear, both quantitative and qualitatively, that the imagined abortion seeker is poor, lazy, often Black, incompetent or unserious, young, untrustworthy, emotionally damaged, and unfeeling and even monstrous. And let me just reiterate, these kinds of images appear and reappear across political ideologies and across abortion identities. So what's important is that what I find over and over is that the consistent kind of set of beliefs is that abortion seekers cannot be trusted and require regulation. And that appears across a variety of ways that people think about this. But for example, in pro-choice identified people, the kind of idea is that abortion should be limited to 1, and then sterilization may be required if they can't control themselves. Different kinds of images that might relate to that. So I'm not going to go into the kind of details of what the data look like, but I want to bring this up because, one, the kind of conversation we're having here today, but also thinking about the upcoming election. There's been a lot in the media about how pro-choice identities have been on the rise post-Dobbs, and that Dobbs really created a kind of kickback. And what's important to know is that when we think about what pro-choice as an identity might include, it's important to know that pro-choice does not always mean pro-choice for all people, pro-choice for all stages of pregnancy, or pro-choice under all context or conditions of that pregnancy. I find in my research and in my colleagues' research, this is often found, which is it's a much more limited category, I think, than the media and the kind of advocacy spaces are imagining. And I think that's incredibly important as we think where we are in the kind of political conversation. So with this in mind, and you're going to hear me talk a little bit about this in the time that I have today, but it's important to know how many people support or oppose abortion care. And I think with the given kinds of measures that we have, often which do not include enough attention to thinking about the really wide variety of pro-choice identities and what that means, we do not know. It is very difficult to know how many people oppose or support abortion care. There's also, I would say, in my research, a great deal of information from participants about their own ambivalence about abortion itself. And again, this is most key, I think, for us thinking together about how this shows up in pro-choice identified folks. And the kinds of measures, the kinds of questions we ask, the kinds of public opinion polls we have do not give us a good way of understanding this ambivalence. And I think ambivalence is a really key idea to bring to the space of abortion attitudes. And one of the ways that I've really unpacked this and am thinking a lot about this is what I mentioned a few minutes ago, which is this imagined woman who is imagined to be taking advantage, finding loopholes, selfish, and driven by seeking a kind of care that is undeserved. So therefore requires regulation of some sort. So with that in mind, that's a kind of brief way of how I'm thinking, which I think, again, is a really good pairing with what Sara talked about, which is thinking about abortion from a more advocacy and how we might think about the barriers that get in the way of pregnant people seeking care. So again, I'm sort of taking a different perspective to think about how psychologists think about attitudes towards abortion, and attitudes towards pregnant people in general. So with that little bit of a background, I'm going to switch gears and talk about exactly what Sara just ended her talk with, and thinking about, I too have been an expert witness. And I wanted to bring these two pieces together because I think graduate students are consistently, and I think great that they're interested in thinking about how might we take this research that we do and bring it into the policy environment. And SPSSI has an incredible and important history in exactly making these kinds of connections. So I've been an expert witness on 2 cases. I've provided testimony in several. I'm going to just go into detail on one of them, which happened in 2018. And I was an expert witness on the behalf of the ACLU, Planned Parenthood, and the Center for Reproductive Rights. And here's just a way of sort of understanding what these documents look like. I think there's a sense of that sometimes this can feel pretty mysterious, so I want to try and demystify just a bit. So just a little bit about the case. It was a Tennessee state law in 2018 that had a 48-hour mandatory waiting period prior to receiving abortion care, which required 2 visits to a medical provider. So there were many really smart experts who spoke to many of the things that Sara spoke to in her previous presentation around costs of travel, lost work time, impact on families, because of pregnant people often already have children. So the kinds of costs that are really important to think about when people have to make multiple visits to a medical provider are what many of the other experts talked about. And maybe what's a helpful way of thinking about this is that the lawsuit was asking the courts to strike down this 48-hour delay as unconstitutional because the mandatory delay, and you heard this in Sara's presentation too, presented an undue burden on women. And what we want to then think about as researchers is, what are all the ways that we could demonstrate undue burden? And the undue burden clause is a complicated one we don't have the time to necessarily go into right now, but it's a really important clause regarding everything related to abortion care. It's been one of the major legal levers that we've pulled on. So let me just pause and say, so what is an expert? What is this terminology and how might I think about it? So an expert has some kind of specialized knowledge, skill, or experience or education which qualifies them to bring what is usually evidence-based arguments to the court. And so what does that look like? It means I, in this case, met with lawyers over about 6 to 8 months. I had about 8 hours of deposition where I was in a hotel lobby or hotel kind of conference room with being grilled by lawyers from the state of Tennessee about both my skill set, previous publications, and all sorts of things related to who I am as an academic, as a professor, and as a researcher. I then flew to Tennessee and gave testimony at the court itself. So what are the things that go into a testimony? I think this is a way of kind of bringing some what it actually looks like. So a good deal of it is about my own expertise. Do I qualify as an expert in the court? What are my credentials? What have I taught? What have I published? And a key piece is, am I biased in a way that then my testimony could not be trustworthy to the court? So credentials is a huge piece of it. But then when we turn to what I brought to the case, as I mentioned before, lots of people and the other experts talked about costs incurred and the undue burden, say, of pregnant women having to travel twice, things that are incredibly important. I turned to the idea that laws and policies have the potential to stigmatize and stereotype groups of people, and that the testimony in this case is that not only do the laws, once they're passed, but debates and campaigns that surround laws can increase negative attitudes towards those who are being targeted by the law. So in other words, the mandatory delay, the waiting period that the law in this case insinuates, stigmatizes women in this case as incompetent decision makers because they require the state to slow down their thinking. So the mandatory delay says, I know you want an abortion, but you have to wait 48 hours and come back. So this 48-hour period then says not only to the woman, not only to the physicians, but to the general public, this person cannot be trusted to make a decision if the state does not slow it down. And so the argument that I made to the court was, this teaches an entire population that women in this case cannot be trusted. So it's a stigma that starts with the pregnant person that then grows and contaminates through this reproduced stereotype that the law is circulating. And with one of the pieces of that being other medical procedures do not require these kinds of delays. So it's a special case that brings a certain kind of attention, in this case, to a pregnant woman. So what my job as an expert in that case was to teach the court about how stereotypes, stigma, discrimination, and attributions work and how this has been studied in the research. So you can see these terms are terms that are deep psychological terms. They are at the crux of what SPSSI thinks about. Many researchers associated with SPSSI think about these ideas. So my job as the expert was to translate that research to the court. And I'm going to show you a little bit just about what that looked like. Just going to check the time. So I then basically summarized a good deal of research about these major topics of stereotype, stigma, and the health consequences of stigma. But really importantly, there is not yet research on these issues, and especially if we think about 2018, there's a little bit more now, but we don't have a good body of research on abortion care related to these issues about how policies contaminate through the role of circulating stereotypes. But we do have research on that in analogous areas, and this is how the law often thinks about things. Even if we don't know about this, we know about other similar analogous situations. So I turn to two analogous situations, meaning that they have some kind of shared relationship with, in this case, abortion care. The welfare laws that require those who are receiving welfare funds to get drug tested, and the really robust research on same-sex marriage policies, where many psychological researchers have turned to the kinds of effects of discrimination related to same-sex marriage bans. So those were the two analogous cases that I turned to that had a good deal of research on them and said they will teach us to think about how this circulating set of laws discriminates at a population level. So you can see I just actually wanted to include a tiny bit of an excerpt to think about what these kinds of reports look like. And so you can just see mandated waiting periods for abortion, like the law at issue in this case, treat the woman making the decision with skepticism. So the law treats the woman with skepticism, calling into question her capacity as an autonomous and capable decision maker. So such policies are built on and help to perpetuate negative stereotypes about women. It's my expert opinion that mandatory abortion delay laws exacerbate gender-based stigma and discrimination. So you can start to see this is what these things include. And I'm going to just kind of conclude as we're thinking about moving on to the Q&A section. I want to end with that there's many ways to contribute to this really important connection between research and public policy. And I'm going to end in the next slide is with advice for those of you thinking about these. So some of the ways we might think about it is research that tests the effects of health and well-being pre and post policy introductions. So before a policy is introduced, including all of the kind of campaigning that might happen with that, and then after the policy. So even if that policy isn't passed, you might think about the period of time after there's been a lot of campaigning, things put up in people's yards, television ads, all sorts of things. And one way you might think about this is looking across groups, right? So it's not just focusing on a singular group, because you want to be able to compare those that are members of a targeted group as compared to those that are not members of that targeted group, because that comparison becomes very compelling to the courts. This has been more difficult, I want to say, with abortion policies, because there is not a clear pre-post, because there's policies that go in and out, there's comparisons between national and federal levels. So I would say that's partly why it's important that we turn to analogous cases, because we often can't see this kind of clear pre-post with abortion care policies. I really want to say quantitative and qualitative can be done and are incredibly helpful to think about this using longitudinal designs. Again, this kind of pre-post thing, but that can be both quantitative and qualitative. And as I said before, the kinds of things you want to make sure to think about is not just that the law was passed, but the whole kind of setting around policy interventions that include lots of things about public conversation that may not rely on the law passing. I also want to say Fingerhut and Frost have a really good set of articles that relate to this. So I just wanted to highlight that. And I have a slide, which I won't go through, but they talk about the Prop 8 case in California, and people and psychologists, including Greg Herrick and Peplau, were incredibly important in thinking about same-sex marriage. So our society and this group of folks have a really important lineage of us going to court, being deposed, testifying, and bringing this kind of research to the courts in order to change policy. So my last slide is just with advice. And this is the most important. I really encourage you to read widely across disciplines, methods, fields. One of the key pieces in thinking about connecting with policymakers, courts, lawyers, is that you can connect dots that they don't know how to, but you do. So the kind of broad reading is my biggest piece of advice. I think also learning and really honing how to write both clearly and complexly. This is really different than the advice that Sara gave, because Sara was talking about reaching different communities, moving research out into the public. I'm talking about moving research into people who demand a certain kind of complexity. So a very different set of audiences. All research methods and designs, I want to say, are compelling to courts. It's your job to show that the research is well done, but across designs, across methods, both quantitative and qualitative are incredibly powerful, I would say, in the courts. I also want to then just end with who you think you might want to be in conversation with. I have found being in conversation with lawyers to be incredibly compelling. The kind of clarity that they demand, but also working within the parameters of existing laws, sets you up as a researcher to understand how you might be thinking about what you want to do. And I'm going to end. I want to just think about, if you want to be thinking about making this a part of your own kind of research domain, to be reading legal briefs, legal decisions, and thinking and seeing how research is talked about in these spaces, I think is a great way of educating yourself about how to do this work. So I will turn it over to Ebony for Q&A.
Thank you so much. Thank you, Sara R. and Sara M. Both great presentations. So we will go to our Q&A section right now. So it looks like the question that we have here in the chat. Okay, it's from Julian, it looks like. Thank you for this session. I want to be able to educate in my organization. What are either some resources to share for a variety of views on abortion, or some methods to share? So either Sara can answer this question.
I guess it depends on where you want to think of as the starting place. Is this about helping folks broaden their ideas of what abortion care is? I would say, given the kind of circulating discourse we have right now, which is inflammatory, but I want to say shows up in every study I've done, which is that pro-choice is advocating for killing infants after a month after being born. I want to say that sounds inflammatory to start there, but I want to say there's two pieces that I think about a lot as kind of helping folks think about abortion differently, which is that is never a pro-choice position, which is abortion after birth. But that is so highly circulating, it is worth just knowing that that might be the place that someone is starting. And two, just the sheer frequency of abortion care. I mean, the numbers have shifted exactly as Sara presented earlier, but that it is incredibly common, happening all the time around us. And that both can affect folks who have kind of strong opinions about abortion care, as well as those who have received abortion care and feel alone and feel like they were the only one that they ever knew because it is so silenced. So one is inflammatory, but we just need to stop letting that circulate. And two, just the normatization of the procedure.
The only thing that I will add to that, and I have to say that truthfully, I'm like I'm scanning my mind for kind of resources that would that do present kind of the variety of different views about abortion. I'm coming up short, so that might have to be something to do some digging on. But one thing to offer, and I can send it, I can share the resource with Ebony and have it sent out to the group, is actually and I offer this as a place to just kind of like further one's education around abortion. Some of my colleagues and I actually put together a massive open online course on Coursera that is called Public Health Approaches to Abortion. And I'll send the link so that folks can check it out, but it's totally free. And it offers, there are, I think, 7 or 8 different modules that kind of discuss all of the different, many different pieces of the discussion around public health approaches to abortion. And that can be a really helpful kind of resource, or it is an introductory course. So I'll just put that plug in because that may be helpful. And we have been getting feedback that it is helpful, particularly for folks who are less well-versed on the topic.
Awesome, awesome. That is amazing. Okay, so another question that we have is, how do racial and gender stereotypes specifically shape the discourse around abortion for women of color?
I'll start here, but Sara, I'd also love to hear your thoughts. I mean, I think one of the pieces that my research has really tried to focus on, I think, has to do with a lot of what this webinar is organized around, which is that the policy conversations predating Roe, so even before 73, and in fact, I want to say through America's history of enslavement, have consistently tied Black women to hyperfertility, hypersexualization, and uncontrollable motherhood. In the sense that the Moynihan report has turned towards it as a criminalizing effort, the ways that the legal landscape has consistently looked to poor women, and the idea that that kind of sexuality and motherhood should be legislated and controlled just has linked Black women and racist ideologies more broadly with abortion. And that is just a long history. There's a lot to unpack there. But what that has resulted in is, I would argue, constant racist attributions to abortion. And that these two things have become tied in ways that, because of our nation's history and our policy landscape, has just reiterated that. And I'm going to add, I think our research measures do it too. So how we are measuring abortion attitudes reinforces this connection, meaning as psychological researchers, we are part of the problem. We are reinstantiating these connections. And I think that, to me, is really important to then think about how our measures circulate information through the public as well. So to me, we are part of this, and it has now borne out in how people think about abortion, and they tie it with a certain kind of set of attitudes that some deserve care, some don't. There are good reasons for abortion and bad reasons for abortion, and that should be consistently legislated instead of held to the person. So we do not imagine people, and women of color in particular, as capable of making good autonomous decisions. And this, to me, is the piece that as psychologists we can and are responsible for undoing.
The one element that I will offer, Sara, is definitely that, this is really her bread and butter. But one real-time example, well, it's not real time, but a real example that I can offer just from my own context was back in 2010, and some folks may be familiar with this, but back in 2010, the Georgia Right to Life, this an anti-abortion advocacy organization, funded a series of billboards around the Atlanta area that said, and with incredibly racist and inflammatory remarks around Black women's access or Black women's abortion seeking. And they had these messages around Black children are an endangered species. And which is obviously a clear example of these racist and racist stereotypes and sexist stereotypes. But I bring up that example to highlight how a community reproductive justice organization responded to that. That is personally where I get a lot of my Atlanta is a home to the reproductive justice movement, and personally, that's where I get a lot of my kind of like encouragement when things feel really hard. It is really connecting back and seeing what our community organizations doing. And Sister Song, Women of Color Reproductive Justice Collective, which is a reproductive justice organization here in Atlanta, actually took that billboard campaign and created the National Trust Black Women Partnership in 2010 as a response to those billboards. And Sister Song, they on Trust Black Women, the movement, there's a beautiful history of kind of like how this movement was started. But in Sister Song's own words, they said essentially these billboards really were really furthering kind of oppression of Black women and saying that Black women are breeding machines with no right to make personal choices about their family creation. So not only do they decenter the autonomy and the agency, but also, failing to acknowledge that people have autonomy over their own decision making around family planning. So that's actually, just an example of a community organization kind of capitalizing on this horrifying campaign to kind of create a community movement out of that.
Thank you. I just want to note that one of the questions submitted was that the Psychology of Women Quarterly is accepting submissions about abortion and reproductive justice. If you are interested or doing work along those lines, that is someplace you can submit.
That is awesome. Awesome. Yes, it looks like Laurel Watson let us know that in the Q&A. So it looks like our next question that we have a PhD student out of WSU in criminal justice and criminology. Their dissertation is on sexual assault nurse examiners. Are there ways to incorporate this into, it's like this is an acronym, SANE or SART training, or other recommendations for SANE working with survivors of sexual assault who become pregnant through assault?
I think that's a great question. And I think actually highlights an important thing that might be worth us saying, which is this is a great example of connecting dots, right? I think the sexual assault, sexual violence movement, which has been advocating for obviously thinking about laws and policies to both help people pre and post assault, but also punish those who are responsible, is intimately connected with abortion care and the kind of advocacy around it. For this exact question makes that incredibly clear. So a great example of movements that need to be connected. I think there's ways then for us to think about what are the effective ways of making those connections. I think one of the pieces that I said a few minutes ago, which is also the kind of normalization of how to think about one isn't the only one who needs that kind of care. So I guess I don't know how to answer that question in the few minutes we have, but I think it's a great example of movements needing to work together. And if we want to think about, for the graduate students in the audience, or thinking about early career folks, thinking about how you might do these things in that the intersection between these kinds of fields, so that makes, for courts that might need to think about two things at once, how do you start to make research designs, topics, research questions that could unify those? Because it's absolutely a key place where we need more work, which I think ties into, as a graduate student, I got to work long ago on a Supreme Court case where I was a research assistant helping researchers make an amicus brief. But it was through the process of reading legal briefs that I got to see where is research needed. And this, to me, is a great example of where we need research to show that people do not necessarily have the agency at the moment of kind of intercourse in this example. So we can't, so many people think that there's kind of agency at that moment. That is absolutely not the case. Not everyone has control over the kind of sexual violence that they experience, which might result in pregnancy. So helping a court understand that, I would say, is an incredibly important research question.
No, again, the only thing that I will add is that I think it's an important question, and I completely agree. This is, an area where these two fields really should be intersecting and, working together more. But I also will just name that the kind of exceptionalism of abortion education is very, very real across disciplines, meaning a lot of times it's not easy to actually get education around abortion, what it is, how to access it, what is, really any kind of disciplinary examination of abortion is very challenging. That's actually this was not a plan for this to be a plug for that Coursera course that I was talking about, but that is one of the reasons actually why we created it. And even, across schools of public health, which is really my domain, there's just shockingly little resources or educational resource around abortion. So I'm not surprised to see that that's a weakness or a limitation of that.
Okay, thank you so much, both Sarahs. It looks like we have a resource here in the Q&A. Okay, this organization may be helpful for training of same-sex CERT nurses. Okay, so it's providecare.org. I think that would be very useful for everyone. Well, it looks like we are out of time right now, but if you guys have any questions, you are feel free to email any of the speakers or myself. I will share my screen briefly to see if we have attendees who may want to do our post survey. 1 second here, because we would love to hear your feedback on the policy series. Okay. All right, so this is our QR code. I hope everyone can see it. Yeah, we would just love to hear your feedback. And thank you so much for attending. Thank you so much for your participation. Take care.
Thanks, Ebony and Leslie. Thanks for all your work with us. It's great.
Yeah, thank you all so much for having us.